Hello everybody and welcome back to Emergency Medicine Quest. In this video we will be discussing bone and joint infections, namely osteomyelitis and septic arthritis. Before we continue, make sure to like, share and subscribe to the channel for more such content. So let's dive in first with osteomyelitis. We know that osteomyelitis is the infection of bone and medullary cavity, and generally, bones are resistant to infection unless there is some major trauma, there is decreased supply of blood, or some foreign body that gets implanted. The inoculation of such infections occur at metaphyses, and that causes the inflammatory cells to move to the area, leading to further edema, vascular congestion, leading to decreased blood flow. Obviously, if there is decreased blood flow, bacteria will flourish, so it becomes difficult to eradicate even with the toughest antibiotics. We know that the most common organism for osteomyelitis is Staph aureus, except in the case of neonates where GBS takes the lead. If there is a bite from animals like dogs or cats, then Pasteurella comes into the picture. If there are puncture wounds or sickle cell patient, then the most likely organism is Pseudomonas. In case of Pott's disease, we know that it is caused by Mycobacterium tuberculosis, and it is specifically in HIV patients. We know that Staph aureus is still the leading cause of causing osteomyelitis, but one organism that we need to be aware of is Bartonella. Basically, it's a gram-negative organism that causes bacillary angiomatosis. Onto the history. Such patients generally come with variable symptoms, but what is commonly seen is fever, rigors, and they just look quite toxic. Examination wise, they will have point tenderness over the infected area. In terms of lab testing, WBC counts can be elevated, but bear in mind that it can be also normal in a chronic infection. And in terms of inflammatory markers, ESR also can be elevated, but it not being elevated is not a way to rule out the disease. CRP raises in the first 24 hours. It peaks at 48 hours and then it becomes normal within a week. But remember, if we are comparing ESR and CRP, generally ESR is better for infections. As for the imaging, X-rays are cheap, they are accessible. What we normally see is lucent lytic areas, but the caveat to this is lucency generally shows when the 50% of the bone mineral has been lost, and it takes 2 weeks to show up on an X-ray. Here is what an osteomyelitis appears on an X-ray. We can see the lucent areas. As for CT, we will also see those lucent areas with gas in the bony abscess. Generally, MRI is better than CT, and particularly its specificity increases if it is used with gadolinium dye, bearing in mind that the patient should not have any contraindication to gadolinium. Bone scans were previously used and they are really good because they can show changes of osteomyelitis as early as first 48 to 72 hours after the onset of infection. But because the burden of radiation is so high in these scans that MRI is generally preferred. As for microbiology, it is the most definitive way to diagnose, and that is to obtain the infected bone by doing needle aspiration or doing surgical dissection. Acute osteomyelitis also makes the blood culture positive, but in chronic cases of osteomyelitis, blood culture will be negative. This being said, if there is a clinical suspicion of osteomyelitis, cultures should be obtained as soon as possible, started them on antibiotic therapy, and then the rest of investigations should be pursued. As for the goal of the management in osteomyelitis, what we want to do is contain the infection before the bone necrosis occurs, because once the bone necrosis has occurred, then the success of treatment goes down drastically. There are two ways we can generally manage a patient with osteomyelitis. In most cases, we need antibiotics, but certain conditions and complications may require the patient to go for surgery. But for ED physicians, the priority is covering the patient for staphylococcus. So generally, this is done with oxacillin, which is a penicillinase resistant penicillin, or we can give first generation cephalosporin, so something like cefazolin or cephalexin. If there is MRSA positive or the patient is allergic to penicillin, then we go for vancomycin. There are certain important subsets of osteomyelitis that we should be aware of. So the number one is vertebral. The risk factor for vertebral osteomyelitis is any indwelling lines, and in young patients who are risk takers, then it's IV drug use. Again, Staph aureus is the most common organism, and mostly it is the lumbar vertebra that is affected. So patients are going to come complaining of back pain. Some of them might even develop neurologic deficits. CRP and ESR will be increased in such patients. And once again, MRI is our imaging of choice. The most dreaded complication of vertebral osteomyelitis is spread of infection to the vertebral canal, development of epidural abscess, or the worst of it all is permanent paralysis. Generally, in a patient with vertebral osteomyelitis, antibiotics should suffice. In cases of post-traumatic osteomyelitis, they normally occur from open fractures, burns, bites, puncture wounds, and hence why these cases are polymicrobial. Imaging modality again remains MRI that we are going to use. In cases of sickle cell, now this is where it becomes a bit different because generally, as we discussed earlier, metaphysis is more affected. In sickle cell, diaphysis is more affected of the bone. In sickle cell patient, it normally occurs due to a hematogenous spread. And we should be aware that salmonella is a very common infecting organism in such patients. MRI once again is the test of choice, and we treat these patients with vancomycin plus ciprofloxacin. Moving on to septic arthritis, which is a true orthopedic emergency. Generally, hematogenous spread is how a person acquires septic arthritis, and normally it affects one joint, so it's a monoarticular process. But septic arthritis can also occur if there is a spread from a contiguous focus of infection, if there is direct inoculation, or from trauma or any iatrogenic procedure. In septic arthritis, much like osteoarthritis, Staph aureus remains the most common organism. The signs and symptoms are joint pain, which gets worse by range of motion, fever, malaise, anorexia, nausea. The patient can be tachycardic. The extremity will generally be inflection, and any range of motion will be really tender. And it comes with the typical signs and symptoms of inflammation. So swelling, warmth, redness. Generally, knee is the most commonly affected joint. In terms of lab work, our basic tests include WBC count, which we can see elevated, but remember that this is non-specific and non-sensitive. We can have ESR and CRP, both of which will be raised in case of infection. For septic arthritis, we need at least 2 sets of blood culture. As for the diagnosis of septic arthritis, it requires a joint fluid aspiration for culture and analysis. If a very small amount of fluid is aspirated, remember the most important single test is cell count. If there is more fluid available, then the rest can be undertaken. Generally, the synovial fluid count should be more than 50,000 for septic arthritis to occur, but in about 30% of patients, it is noticed that this count is less than 50,000. Make sure to evaluate the joint fluid for presence of any crystals, because this is going to help us differentiate between a inflammatory and a non-inflammatory process. In terms of imaging, X-ray is not the best test when it comes to septic arthritis, especially if we are considering early evaluation. Ultrasound is really helpful because it helps us visualize the joint effusion, and it can also help us in aspiration. As we approach towards the end of this topic, I'll conclude by talking about management of septic arthritis as well as some clinical subsets that we should know about. In terms of management, the priority is as soon as we suspect septic arthritis, we should have fluid aspiration and start them on empiric antibiotics. If we are suspecting a gram positive, which will be majority of the cases, we start them on oxacillin or cefazolin. If we are suspecting that the patient can have Neisseria, then we will give them ceftriaxone. And for Pseudomonas, we normally give them piperacillin. One important subset in terms of population of septic arthritis are children. So, prior to vaccination being globally available, the most common cause of septic arthritis in children was Haemophilus influenza, but now post vaccination it has become Staph aureus. In neonates, however, GBS and Staph aureus can equally affect. Some literature says GBS more than Staph aureus. We have something known as Kocher criteria, which basically helps us determine if the patient is going to need arthrocentesis and orthopedic consult. So there are basically 4 criteria to it, but coupled with CRP, it makes a good tool to use. So is the child febrile more than 38.5 degrees Celsius? Is the WBC count more than 12? Is the ESR more than 40? And is the patient unable to walk? If the child meets the Coker criteria, obviously the more criteria he or she meets, the more likelihood of septic arthritis and hence more the need of arthrocentesis and orthopedic consult. The second subset to talk about is gonococcal arthritis. Normally it comes with this triad of polyarthritis, tenosynovitis and dermatitis. The migratory polyarthritis is usually asymmetric and mostly it affects the knee. Hemorrhagic pustules can also be seen at skin, and generally these patients will present with classic signs and symptoms of a septic joint. We should bear in mind that when we aspirate fluid from these patients and send it for analysis, WBC count of the synovial fluid is usually less than 50,000 and the gram stain is only positive in 25% of the population. Treatment wise, we treat them with ceftriaxone or any third generation cephalosporin should suffice. The final category is periprosthetic joint infection. The two things that we need to know about this is that the most common etiologic agent for this is not Staph aureus, it is Staph epidermis. And the next thing we need to know is the diagnostic criteria if we aspirate fluid from them for septic arthritis, which we remember as 50,000. Here it is at least more than 1100 with neutrophilic predominance. Neutrophils should be more than 64%.